Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Jack McGeachy. He's an emergency and addiction physician. Today's KevinMD article is titled, Physicians Have a Hidden Addiction Treatment Superpower. Jack, welcome to the show.
Thank you so much, Kevin. I'm really happy to be here today.
So let's start by sharing your story and journey to where you are today.
Mhm. Yeah. So I didn't start my career thinking that I would, treat addiction, but it really kind of found me. So I trained in emergency medicine at the University of South Florida. And during my training, it was really the peak of the initial, you know, opioid epidemic wave. And I was seeing repeatedly, patients coming in suffering from the complications of their addiction, in particular, young people who were suffering from endocarditis and other serious life threatening infections from IV drug use. And so this really, motivated me to look into see what we could do. And at that time, emergency medicine really did not see itself as primarily responding to people with addiction. We would reverse these people with naloxone, watch them in the emergency department, and discharge them to the streets. But I found that there's actually a growing movement to bring buprenorphine into the emergency department. And at the time, we had no such program at Tampa General. So actually, as a resident, I started working on a pathway so that we could identify and treat these folks and start them on buprenorphine, link them up with care in the community. And it succeeded, beyond our expectations. And just participating in that and seeing the difference that we could make in a patient's life was just so gratifying. It was really amazing and has led me to, learn more. And, the biggest takeaway that I want, to leave the audience with is that you can do this. Physicians are actually very uniquely centered as medical professionals to provide care to patients with addiction. We have a very unique set of skills that lets us address all three of the domains that characterize the disease of addiction.
So just before we move on and talk about this in more detail in your KevinMD article, let's get everyone on the same page. Give us a 30-second summary
Mhm.
of what buprenorphine is and how is it used today.
Yeah, that's a great question. And I know not everybody is familiar with the medication, but buprenorphine, in a nutshell, is a very effective treatment for opioid use disorder. It is a partial mu agonist in contrast to full agonists such as morphine, oxycodone, fentanyl, methadone. It binds to the mu receptors, but it doesn't fully activate them. And this really has two chief benefits. One is that it alleviates the withdrawal of opioid cessation and prevents cravings. And in this way, it can very effectively treat opioid use disorder. And it's more than just substituting one dependency for another. These patients derive great benefit from treatment with buprenorphine. Once they're stabilized on buprenorphine, they can start, picking up the pieces of their lives and working on their recovery. And it saves lives. No bones about it. Buprenorphine saves lives. It prevents, the complications of opioid use, in particular, the infections that patients can get from injection. It saves them from the legal consequences of seeking out illicit opioids. And in that way, it protects them. It also is protective from overdose as well. Morphine binds so strongly to the mu receptor that very few opioids can replace it. And in that way, it sets the patient's opioid receptors at a certain ceiling that protects them from overdose. And so in that way, it's just a fantastic drug. I think I went over 30 seconds, but I'm just so excited about buprenorphine.
All right. And we're going to talk more about that in your Kevin MD article. Physicians have a hidden addiction treatment superpower. So you mentioned earlier about kind of the three parts of this disease: the biological, the
Mhm.
psychological, and the social domains of this disease. So maybe as you lead into that Kevin MD article, maybe start there and go into a little bit more detail.
Yeah, certainly. So, addiction really is a tripartite disease, and there are three major domains of dysfunction. There is the one we're most familiar with as physicians, the biological, and that centers around dependency, tolerance, the physical consequences of drug use, and the complications thereof. The second is the psychological domain, and this refers to the disordered thoughts and beliefs that lead to the addictive behaviors. And then the third is the social. And this is the one that I think people have the hardest time wrapping their heads around, but it is a very broad domain. And it's good examples would be the isolation that we see in people with addiction, um, their dysfunctional interactions with their friends and family and society at large, the legal consequences. It could also include their socioeconomic status, their housing status. And so, in brief, to properly treat substance use disorder, you really have to address all three. But, like I mentioned in my article, as physicians, we're actually very uniquely suited to do that.
So talk about some of the next steps in terms of how specifically physicians are suited to treat
Mhm.
these three domains.
Yeah. So, as far as the biological domains go, we are the masters.
Hmm.
There's really no other medical professional who has the unique training and skill set to address the biological aspects. In that way, I feel most physicians are rather comfortable with treating that that part of the disorder. But we also have, you know, the soft skills as well.
Hmm.
Day in and day out, you're dealing with, similar issues in your patients with chronic disease like diabetes and hypertension. If you just write a prescription for amlodipine, it doesn't guarantee the patient's going to take it. So, we are well versed with how to address these issues. And treating, the psychological needs of a patient doesn't mean that you have to learn cognitive behavioral therapy or become a Freudian,
Hmm.
psychoanalyst. It's great if you have those skills. And I will say that it's not as difficult as you might think to gain those skills. But by just applying what you already practice, with your other patients with chronic disease, you can really make a difference in these patients' lives. And one thing that I learned personally as I was on my on this pathway to becoming a addiction physician is that patients really value that relationship they have with their doctor. And in that way, you're providing for their social needs by just being there for them, and also providing a sense of accountability as well. That's really powerful. And that's really unique as well. In most other treatment programs, it's a it's an entire cast of characters that's caring for the patient, and they may not really feel any sense of accountability to any particular one. Patients, derive a lot of benefit from having that relationship with that one bedrock person that they see on a regular basis and trust.
Tell us a story. Give us an example or anecdote in the emergency department setting where you have made a difference in these domains so that could
Mhm.
really bring this to life.
Yeah. So, as part of our treatment pathway, I interacted with, a number of these patients over the years, and also incidentally saw them on my shifts as well. And I remember in particular, there's one young man who he had a very difficult life. He really didn't have any friends or family. He was unhomed and would frequently miss doses of his Suboxone at the treatment center. So he'd come into the ED to get dosed. And, we would talk, regularly about his case and express our concerns. And, I happened to be his doctor one day when he came in to get one of the doses he missed. And I sat down with him and I said, hey, you know, I think that you're doing a great job. I know that it's tough, and I'm just happy that you're, instead of giving up, you came back, and in the future, I really want you to work on trying to make it to your appointments, but I still think that you're doing a great job. And, at the time, I really didn't think much of it, but I was told, the next day by one of the counselors that, cared for him,
Mhm.
that made a real impact on him. And he told her, and, in that way, I was able to be there for him and provide that for him.
Now, you mentioned earlier that you started a buprenorphine program in your emergency department, making a huge difference in a lot of these patients' lives. How common is it that emergency departments across the country have programs similar to that?
It's a great question. And I think that, we're really in the heyday of ED initiated buprenorphine, which is wonderful. It's an idea that comes out of the Northeast and Yale, but it's really filtered down. And I know in Florida, it's it seems like almost every hospital, even the small ones, have been setting up programs, which is wonderful. A colleague of mine told me about a program in a rural county where they actually have the fire chief come out to the patient's home or wherever they want to meet up if they have no home, and induce them on buprenorphine after a ED visit, which I think that's great. And the particulars of the program is going to look different at
Mhm.
each particular hospital. Um, but yeah, I think it's really picking up. Yeah, I think
And
people are
in
really
your
picking up on it.
and in your case in Tampa, patients who are started on buprenorphine in the emergency department setting, are they then going to a clinic afterwards? Do they go to their
Mhm.
primary care physicians who then continues their buprenorphine? What happens in terms of follow up?
Yeah, it's a great question. So with our formal program, we have a partnership with local treatment centers where the patient will follow up and be cared for. But you could see the model working with a private physician as well. And there really are very few barriers in 2023 to a private physician adopting this as part of their practice. And that's really, I think, what the aim of the goal of my article was trying to get across is expressing this, that you can do it absolutely, and it's well within your skills. I know it just it's scary, especially if you didn't learn much of this in med school or residency, and probably haven't practiced it prior. But it, with the buprenorphine in particular, it really is a powerful tool that is and expanding access. Unfortunately, it's not used nearly as much as it should be, and even the feds say that they were hoping that by removing barriers it would expand access, but thus far they really haven't seen it.
How about in a primary care setting? So let's say we
Mm-hmm.
have primary care clinicians who are listening to you now and are inspired to take that
Yeah.
first step. Tell us the first thing that they should do in order to address
Mm-hmm.
this.
Yeah. So after take some time to familiarize yourself with the basics, which of prescribing, which shouldn't take long. It's not too complicated from that end. I think the real first step is screening your existing patients, because I unfortunately, addiction is far more widespread than we even, you know, recognize currently. And it's something that's not difficult in, in theory, but in practice, it's hard to implement. But once you rip the band-aid off and and, start the conversation. Most folks are very amenable to at least listen. Not every patient will be ready for treatment, but if you let them know that the opportunity exists, you open up that space for healing.
And if one were to begin prescribing buprenorphine, what kind of training is involved in doing that?
Yeah, great question. So prior to 2023, you needed to get a waiver to prescribe buprenorphine for opioid use disorder. After 2023, as long as you have an active DEA license and can prescribe Schedule 3 drugs, you can prescribe buprenorphine for opioid use disorder. No waiver is required anymore. I still think it's beneficial to take some training, but it is not legally required anymore.
And when prescribing buprenorphine, what are some signs that we need to be careful of when prescribing it?
Mm-hmm. Yeah. So overall, I want to begin by saying that it is a very safe medication, but there are some things to be mindful of when you're starting a patient on buprenorphine, transitioning them from a full agonist opioid. It is possible to precipitate withdrawal, which can be very distressing to the patient, but not physically harmful. And there are strategies to prevent precipitated withdrawal. As far as medical contraindications, relatively few. There are some reports of hepatitis or liver injury in patients who have an underlying liver condition, and so it's good to perform regular screening labs and also be on the lookout for signs of hepatitis or liver failure, but that's relatively rare. It's hard to overdose on buprenorphine because there is a dose ceiling, and most adults who are already dependent on opioids, that dose ceiling is not enough to cause respiratory depression. Although children who inadvertently takes buprenorphine can overdose, and so you should counsel your patients to safeguard their medicine. There are some case reports of overdose in patients concurrently using benzodiazepines, but in practice, it seems that that's relatively uncommon. Really, you really only see it in people who are misusing their medicine by injecting it.
We're talking to Jack McGeachy. He's an emergency and addiction physician. His KevinMD article is titled "Physicians Have a Hidden Addiction Treatment Superpower." Jack, tell us some of your take-home messages that you want to leave with the KevinMD audience.
Yeah, absolutely. My biggest take home would be just to, believe that it's possible. You can do this. There's thankfully in 2023, there's relatively few legal barriers to treating addiction among your patients. It's well within your skill set in your wheelhouse, and the need is there. The need is certainly there. And if a physician, decides to take it upon themselves to address this chronic disease among their patients, they are doing a great service. And, the last thing I would say is it is so gratifying to treat patients with addiction. You will see the most tremendous improvements in quality of life. You can take a person who is very, sick medically and whose life is in shambles, get them into treatment, and their life will do a 180. And it's so gratifying to see that. I encourage all your listeners to learn more. If anybody is interested in asking me any questions, I'm open for that as well. I'd love to, talk further if you're interested.
Jack, thank you so much for sharing your time and insight, and thanks again for coming on the show.
Yeah, thank you, Kevin. It was a pleasure.